Hello guys, hello family. This is Dr. T speaking. Dr. Tembile Nofingana. People have been asking my full name and surname. Yeah. So to make it easy for you guys, I don't mind if you just call me Dr. T, which is Dr. Tembile. That's my name. So guys, welcome to this episode. And if you are watching us for the first time, welcome to the channel. Clinical Medicine with Dr. T. We really try to make medicine look simple because it's really not difficult, guys. It's really not difficult. Yes, people would like to make it look like it's difficult. Medicine is not difficult. It just needs us to study, sit down and study. And yeah, so welcome to today's chat or discussion. And today we're going to be tackling biliary tree pathologies. Obviously, this is surgery. Biliary tree pathologies. Just a very quick reminder of the anatomy there. It's very important that we remind ourselves. So that's our liver, right and left hepatic duct. They form and they come together and form a common hepatic, which is later joined by the cystic duct. And then that's our common bile duct. Cystic duct. This is our gallbladder. This is our left hepatic, draining the left lobe of the liver. This is our right hepatic. This is our common bile, and then this is our common hepatic. It's very important, guys, this anatomy. And then we're gonna have our pancreas there. And I know this is too far. Nothing is drawn to scale here, guys. Nothing is drawn to scale. Ampulla of fata, and we've got our mouth there, ampulla of fata, and then we're able to deposit our bilirubin there. So when we talk about, or when we talk of biliary tree pathologies, we are basically talking about pathologies that involve this part. Those are our biliary. There are so many of them, guys. There are so many of them. But the number one problem in the biliary tree is gallstones. Gallstones and its complications. Yes, you get your cancers there, your cholangiocarcinomas, your head of the pancreas cancer, you get TB, lymph nodes obstructing that kind of a thing. You can even get so yeah, basically that's what we're talking about. But because it's a big topic, biliary tree pathologies, so we're gonna take it in small bits, small chunks, chew them, digest them and assimilate. And yeah, and please guys, don't forget to hit that notification bell so that whenever I upload, you get a message. Okay, so what we're gonna talk about now is gallstones. Gallstones. If you wanna be fancy, Cholelithiasis, then you are fancy. Okay, so there are two types of stones, right? We've got pigmented or pigment stones. We've got cholesterol stones. These states, they say they okay about 20%. They're not common in South Africa. These they call about 80%, very common in South Africa. And the reason why these are not common in South Africa is because of their risk factor. these are due to, these pigment stones are usually black, they are brown sometimes. They are mainly due to an increased hemolysis. So when you've got an increased hemolysis for whatever reasons, but it's usually those weak red cells, those abnormal looking red cells like thalassemia, sickle cell, sideroblastic, they call those kind of cells. You know, those sideroblastic cells, those sickle cells, those ones are prone to rupture, to hemolyze. So then you end up having an increased turnover of bilirubin, and then it becomes so concentrated that it starts crystallizing and forming stones. So you get those pigment stones. So the risk factors is that. That's why those conditions are not common in South Africa, and that's why we've got pigmented stones are not common in South Africa. Yeah. So, and then we come here, these are the common ones. And because of these risk factors, I'm sure you guys know about the 5 F's. So these stones, there's cholesterol there, and then there are other things, there's calcium, other things as well in those stones. But for me, or to me, a clinician, the type of stone is not important because the presentation will be the same and the management will be the same. So the type of stone is not really important for me. So yeah, the 5 F's. So these are the risk factors of cholesterol stones. The 5 F's, the first F is when you are fertile, meaning when you're in your reproductive years, you are female and fertile, you are 40 and above, you are, sorry to say this, but you are fat, which is obesity, female, 40. Guys, please check the last F, ne? It's very important. Please look it up, because if I now sit and think about it, I'm gonna exhaust my time. So think about please check that. So those are the 5 F's. So these are the types of cholesterol of stones, pigmented stones or cholesterol stones. So now, how do they present these stones, ne? Let's talk about how do they present. Doesn't matter which type, but how do they present? Presentation. Gallstones, in many patients, they are asymptomatic, meaning the patient doesn't experience any problems. They are running, playing soccer, playing whatever, and then they have gallstones, but no one knows about it because they're not presenting. But you can have them as an incidental finding, or you can have those people who go on and become symptomatic. So this is how, if someone asks you how do gallstones present, so they can present in 3 ways. 1, we've got patients that are asymptomatic. Number 2, they can be found or diagnosed as an incidental finding. And when you talk about incidental, there are 2 things that you must keep in your mind then. It can be intra-op, or it can be by imaging. Let's say an incidental finding. An incidental finding is when you're not looking for it, but you find it. Like here, you are doing an operation for something else, and then you happen to see the stones in the gallbladder, and then you make that incidental finding. Maybe the patient had a strep abdomen, so you were busy maybe repairing that, whatever you were operating. That's intra-op incidental finding. But you can have maybe you're doing an ultrasound in the abdomen, and then you find, or the sonographer tells you that actually the patient that you sent has got stones. Then you're like, oh, do you know about that? Because they're not symptomatic. And then you can have those who become symptomatic. Let's talk about these ones that become symptomatic. Why do they become symptomatic? It's very important to understand. Let's just create space for ourselves here. So why are the people who become symptomatic? Why do they become symptomatic? And those who are not symptomatic, why are they not symptomatic? Let's talk about that. But it goes down to how well you understand the pathology there. So guys, like I'm saying, this is not drawn to scale. Remember, the gallbladder, if you look the underside, the undersurface of the root lobe, there's an indentation there where the gallbladder sits. So you are not supposed to see it like this, but I've taken it out for us to be able to appreciate it. So you have got you've got those risk factors above there, and then these are the stones that we are having. Stones that are sitting like that will never be symptomatic. So this is the asymptomatic patient and your incidental patient. Remember, the incidental finding it's patients who are also asymptomatic as well, but we happen to diagnose them because of the imaging or the surgery that we're doing or the operation that we're doing. So those ones they've got stones that are just sitting here. As long as the bladder is able to drain its bile, its bile, as long as it's able to drain its bile and it goes all the way to the duodenum, it's not going to have a problem. But the problem comes when one of these stones now decides to be clever and then they come and sit here. So when it comes in, when that stone sits there, the bladder will sense that, okay, I'm not able to drain. And then peristaltic movement are going to start in this gallbladder wall and try to force that stone to dislodge or to move away from there. So those are the patients who become symptomatic, because now they will have what is called a biliary colic. Biliary colic. So they will start having a right upper quadrant pain. They'll start to become nauseous and sometimes even vomit. They'll start to become sweaty, diaphoresis. They'll just feel unwell, and they might be anorexic, so that's how they will be. So it's because of the bladder trying to push. Remember, there's a smooth muscle there that is there. So a colic pain, I'm sure you guys know what a colic pain is. A colic pain is a pain that it must come, for it to be colic, it must come from a smooth muscle. So its source is a smooth muscle. So you get it from a smooth muscle, and it's usually a pain that is trying to propel whatever that is obstructing the lumen. So it comes like in waves. It comes and goes like that. It comes and then becomes very severe, and then it stops and then it comes again. That's like a colic pain. So you will have these symptoms on this patient just because of the bladder trying to dislodge the stone, try to push it. These patients might come and say, I had this pain, it was very bad, and they describe a biliary colic. But now when they come to you a week later or so, if they didn't come to you when they had they were symptomatic, they come to you and they're like, I had this and then as a doctor you come up with sort of like differentials and you think, oh, let's have an ultrasound, and then you do an ultrasound, you find that, oh, actually they've got stones, but now they are fine. The reason why they feel better is because once this stone sort of like dislodges and comes back here, then this will be opened, and then what that force, that peristaltic movement that the bladder was trying to use to push the stone out is now gonna stop because the stone is now back here. So then the opening of the cystic duct becomes patent again, so there's no need to try and propel anything. So then the patient becomes fine. That's that. But now if they do actually come to you because of this, remember, right upper quadrant pain has got so many differentials, and so many of them are complications of a gallstone. So how do you say that this is just okay, let me explain something. Gallstone disease is a patient who's got gallstones and then they become symptomatic. But when someone just has got stones there, it's just cholelithiasis. it's not a disease, it's just stones that are in the gallbladder. So it's uncomplicated, there's nothing complicated about it, they are asymptomatic. But once they become sick from the stones, then it becomes now a gallstone disease. So they will come in, so you examine them, you look at their BPs. Their BP must be fine. Their pulse can be high because they are in pain. You know, one of the causes of tachycardia is pain. So that one might be high, but the blood pressure must be normal. Because if the blood pressure is normal, let's say the blood pressure is low, it might be a sign that maybe they are in shock, septic shock. Because if they've got acute cholangitis, because at this point you don't know, because the complications of gallstones, which will eventually maybe even kill the patient, we have not ruled out. Because from this, you cannot just say that this is a gallstone disease and then you need to rule out the other more problematic conditions there. So the blood pressure must be normal, and these people must not, they can appear in pain, but they must not be sick, they must not be toxic. So their vitals must be okay, and when you examine them, the abdomen must be not distended, it must be soft, it must not be tender. The minute you find tenderness on the right upper quadrant, let's say we find a Murphy's sign, then that's not gallstone disease anymore, that's cholecystitis. So the management of gallstone disease or the cholelithiasis is different from cholecystitis or acute cholangitis or whatever. So it's different. So you need to make that differentiation. So when you examine the abdomen, your abdomen basically must be NAD. There must be no abnormalities on your examination. And then another thing that needs to be done is the investigations. You can do imaging, and then you can do bloods. When you do bloods, which is the easiest thing that everyone can just do, when you do bloods, you do a white cell count, you do a CRP, you do this should be normal, CRP should be normal, and when you do a lipase, remember acute pancreatitis can also present as a right upper quadrant pain as well. So you wanna miss that, especially if someone has got a history, maybe they are diabetic with hypertriglyceridemia, or maybe they maybe even complications of gallstone pancreatitis. When you've got gallstone pancreatitis, you've got pancreatitis from gallstones, you will be able to pick that up using your lipase if it's high. Or maybe you've got, the person is known to be using excessive alcohol. So these are the things that you want to rule out. You want to do the lipase, check for pancreatitis. You want to do you can do your Biliary and see if you're not having maybe an obstruction, like in obstructive jaundice, things like that. You want to do your ALP and see if you are not having yes, still obstructive jaundice, ALP. You can also do your transaminases or your aminotransferase, and also, and what else can you do there? So those are things that I can think about now. So, but those must all be normal. And now when you do an ultrasound, the sonographer comes and say, oh, actually there are stones in the gallbladder. Now you make your assessment and say, oh, okay, oh, we've got gallstone disease here. But the minute you find any of those abnormal, then it's no longer pure gallstone disease. There is something else that there's a diagnosis for that. We are going to talk about okay, let me just, while I'm still at it, let me just mention these things. We are going to talk about them one by one. So right now, we are talking about gallstones. Okay, let me be fancy and say cholelithiasis. Cholelithiasis, which can complicate and cause cholecystitis, or complicate and cause cholelithiasis, which can complicate